Ready to go. Right, over to our first talk today, which is very, very relevant after just hearing what Ruth had to say. So our first session is Innovative Ways, Practices and Managing Patients in Primary Healthcare During COVID. And I think this is really interesting because I don't know about you, but certainly in our practice, we're just completely getting smashed. It's really hard to keep up with patients' demand. And I think thinking about how we can do this differently is so relevant. So I also want to thank the University of Melbourne Rural School sponsoring this session. So our first speaker is Millie Gilatti, and Millie is a program coordinator and wellness nurse for the PHN-funded Chronic Conditions Model of Care program. It's called Put a Spring in Your Step, and she's going to talk about that today. Millie entered primary healthcare as a primary healthcare nurse 2 years ago and brings 10 years of strategy and communication skills to the program. Thanks, Millie.
Well, hello there. I hope everyone can hear me, and thanks for coming today. So what I'm going to be talking about is our program, Put a Spring in Your Step, and how we have adapted to COVID. So I'll give it a little bit of an overview and obviously explain the impact of COVID briefly, but most importantly, what our response was. So looking at group exercise sessions, our prehab program, and also mental health workshops. And then I'll touch on to what we're looking to for the future. So we're a rural Zone 4 community-based wellness program running since 2017, funded by the Western Victoria PHN as part of the Chronic Conditions Model of Care program. The program aims to reduce risk and hospitalisation, improve quality of life, and increase self-management abilities through improved health literacy. So we work with a variety of different chronic conditions listed there at the bottom, and we have had over 3,000 referrals since beginning and delivered over 25,000 occasions of care. So we're really proud of where the program's at. So this is a snapshot of our program. All elements of the program are based on Wagner's chronic care model. And we've got their delivery system designed through health and physical assessments. And a key focus of the program is self-management support. So that's our physical activity, where we deliver 2 exercise sessions per week. And also health education, both online and through face-to-face workshops. A variety of different topics we cover there. So pain management, mental health, medication use, benefits of exercise, healthy eating, and advanced care planning. We also offer nursing support, telehealth and face-to-face as needed, and discharge planning, which is obviously a key part of the decision support for the patients and finding relevant pathways to action for them. What clinical information systems are our clinical notes, enabling us to have a really coordinated approach to our care, and organisation of healthcare is really kind of what Springs bring to the table. So we're really, really lucky to have senior leadership engagement. They really support our program. We're a multidisciplinary primary healthcare practice with a network of allied health professionals. And we're often the first port of call for high-risk patients. So we can really kind of get those referrals through and get them into the program. We've got centrally located facilities in modern buildings, which really, really helps us engage with our patients. It's a great place to work. And really importantly, we've got an established clinical risk group to promote best practice and keep our staff and patients safe. So in terms of COVID-19, I'm sure we all kind of know the impact of COVID, but just to briefly touch on a couple of things. Our program is predominantly face-to-face, so we did have to adapt to a telehealth model, doing exercise classes online and providing home exercise classes. our education really stalled as we slowly transitioned online. That was a big struggle for us. But elective surgery wait times, this is from the Australian Institute of Health and Welfare. From 2019 and 2021, 4.1% of patients were waiting over 365 days. And there was an increase of 120 days for 90% of patients admitted to surgery. ENT, head, neck, and orthopedic surgeries were seen as the highest proportions of people waiting over 365 days. And you can see there from the mental health aspect, just a quick snapshot to show the increase in calls to both Lifeline and Beyond Blue were quite significant, reflecting the impact on mental health. And we definitely saw a reflection of that for our patients. And when I was doing a bit of reading, the Lancet Rheumatology, this really struck a chord with me. Osteoarthritis is ranked by the World Health Organization as among the top 10 most disabling diseases in high-income countries. And ADLs, chronic pain associated with substance abuse and impaired mental health. And clinical depression due to pain is seen in 60% of those waiting for knee replacements. And it suggests that these surgeries are seen as less priority compared to those for patients suffering from cancer, for example. And delaying surgery more than 6 months projects 50% greater odds of worse outcomes. So look at that from our program participant and community perspective. Here's just a couple of examples of what we saw in our community. So we've got a 73-year-old male who lives at home with his wife with AF and OA in his left hip. Pre-COVID, swimming twice a week at a local pool, joining our exercise groups, really enjoying life, independent, pretty upbeat. And during COVID, we really saw a significant decline. He started ambulating with a stick, and he reported significant pain, reduced quality of life, independence, and self-esteem. But his ablation to obviously help treat his AF was completed in August 2021. But his hip replacement, he was told he was going to have to wait for at least 10 months. Again, a 68-year-old female living alone in a rural village, osteoarthritis. Again, pre-COVID, twice weekly exercises, ambulating independently, and really engaged in the community. And during COVID, reported a significant decline. Pain, isolation to drive because of the pain, and increased anxiety and ability to cope. And whilst I obviously acknowledge there is a natural progression of disease, it was really sad to see the decline of people, suffering with pain. In terms of general cohort, access and skills and confidence around technology and accessing telehealth services was really hard. A lot of people had problems, don't even have access to poor connection, etc. When we were trying to get people to exercise, there is obviously sort of challenges around safety of them doing it remotely or alone. And engagement and a feeling of sort of helplessness was seen definitely between staff and patients. So how did we respond? I think it's important to approach, because we really did do this consciously. We wanted to be adaptable and do what we could and respond to our patient and community needs, no different to what they were previously, and seek opportunities rather than focus on the desire to return back to normal. So the key things that we looked at were our group exercise sessions, our prehab service, and mental health workshops. So in terms of exercise sessions, prior to COVID, we're gym-based, but obviously meant that we do home exercise programs. As restricted, we went outdoors and were exercising in a group style format. And now we've taken those learnings and we're continuing our group exercises, but indoors, because obviously I'm sure everyone knows that the weather is a bit of a challenge. But one thing that we have acknowledged is that these outdoor, indoor, and home exercise programs are not appropriate for falls risks. And that's for a lot of people waiting for surgery. They might not be stable enough on their feet to exercise in this format safely. So that is where we've looked at our prehab service, which I'll talk about next. But just touching on our exercise programs and doing them now in a group format, we really learned through the COVID that gyms were quite overwhelming for people, and actually simplifying our exercise, doing it in groups and getting huge benefit from social interaction, and also taking the benefits that people can adapt these exercises to do at home for long-term self-management was a huge benefit for everybody. So that's where we looked at our new service for people waiting, probably waiting a little bit longer than they may have done previously. So this is gym-based exercise sessions with individual exercise prescription. Really, although we do look at the whole, we're making sure that we're focusing on the. And whilst we do have our hips, we also are working, for example, with a male waiting for a lung transplant. So that individual prescription is very important. And whilst our main program is 14 weeks long, we have extended the length of this program to ensure that we can support people right up until surgery. We're coordinating care with the GP, allied health team and nursing team, just to make sure that we're all on the same track and for the best health outcomes. And we're providing access to workshops to help promote overall health, and specifically mental health. So that's a new initiative we've just starting. So this is about developing strategies and skills to promote mental health. So we've partnered with some mental health social workers and Centre Self Collective to deliver interactive workshops. So we've got one about self-care and well-being, really trying to provide people strategies to improve or retain their mental health through self-care. And the second one is adjusting to chronic illness, finding meaning and purpose. We find a lot of people say, I used to be able to do this, I used to be able to do that, but not anymore. So how can we help them find value and purpose moving forward? So where to from here? We are always looking to review and refine. We listen to feedback, regular team meetings reflecting on feedback and our own experience. And we have quarterly management meetings and quarterly PHN meetings to reflect and share and improve our program. We're always looking for sustainability options. So there we've got the chronic disease management allied health visits. So that's the old 5 EPCs. How can we use those? Multidisciplinary case conferences to increase care coordination and improve health and provider relationships. And then also, how can we use the 10997 practice nurse mentoring and support item number to really kind of facilitate patients setting and achieving their own goals. So thank you very much. That's just made it just in time.
Thank you so much, Millie. That's so excellent. Can I ask, where are you based, Millie? Is this local?
We are practices are in Daylesford, Kyneton and Trentham.
Okay.
So yeah.
Excellent. I'm just checking. We haven't got any questions, but people are welcome to put questions in the Q&A for Millie before we get started with our next. But it sounds like an excellent program and so needed. It's being coordinated.
Our main driver of referrals now is word of mouth through the community. So that's are really, really great to know that our patients are finding that they're getting what they want out of it and telling their friends,
Yeah.
So that's great.
And it's so daunting for so many people to use sort of mainstream exercise programs. I think, there really is a lack of exercise programs that people feel, that they can feel welcome and that they're getting something out of. Like going into a normal gym is just, so daunting for a lot of people, isn't it? Yeah.
Yeah, well, we found that although people would be in the enjoying, ready to leave because they didn't want to go.
Yeah.
Yeah.
Well, thank you, Millie. I think in time, because we're pressed for time, I might introduce our next speakers that working for another innovative ways of care. Oh, hang on. I've got a GP here, Danielle. I might just read this question. I'm a GP working at Springs Medical and love Spring in Your Step program. Being able to refer patients to a graduated exercise program is fantastic. Especially as most of them would never set foot in a gym. I agree word of mouth is good. Everyone tells their friends about the program and they're reluctant to leave when they finish. So that's a great thumbs up. Greg, I may have missed the start. But where did the seed funding commence the program? And I think where did you get money to get this started?
So that was a tender through the Western Victoria PHN for the Chronic Conditions Model of Care in 2017. We've just got one more year, so we shall see what happens after that.
Yeah. I suppose it's looking. And you were based at the Primary Healthcare Network. That's where your role is. That where you're.
No, I'm actually a new nurse that came to work for Springs to work on the program. So
okay.
I wasn't actually around at the beginning.
Okay, excellent. Okay, well, I'll move on to our next speakers. I think that's all we are for questions. So I'd like to introduce Michael and Karen. So Michael Axten tells me he's a burnt-out GP, but passionate about patient-centred care. He also tutors communication skills, which he loves. And he wishes he developed a nutritional and lifestyle literacy earlier in his career because he's so passionate about it now. His current passion is restoring metabolic health way earlier in people's lives using shared medical GP appointments. And Karen is a nephrologist and a transplant physician with an interest in metabolic health. In 2020, Karen became a fellow of the Australasian Society of Lifestyle Medicine and is undertaking training through the Society of Metabolic Health Practitioners. Karen is the clinical director at Kidney Health Australia and professor of medicine at Deakin University, and she's passionate about improving health and well-being of the community, gender equity and holistic medicine on an emphasis on lifestyle management. And they're a great team. So over to Karen and Michael and their project. Thank you.
Thank you. So thanks for the introduction, Anne. So I'm here with Karen and Jack hiding in the background. So we've got an extra presenter here. So look, I'd just like to acknowledge the traditional owners of the land on which we're meeting. It's Wadawurrung country for us, of the Kulin Nation and the world's longest practicing First Nations people, and the relationship with land, sky and water. And we pay our respects to elders past, present and emerging. Oh, just to mention GMHBA and Deakin, but both of us have involvement with each of these organisations, and I've done some shared medical appointments with GMHBA a couple of years ago, and we're currently running some in private practice, but we're also doing research as we do it because we want to show outcomes. So I think you heard a little bit about shared medical appointments yesterday. They're a series of consecutive individual medical consultations, so in a group setting, but each person gets their appointment and it's witnessed and participated in when facilitated by others. So it's a really good way of cross-fertilizing with information. And so part of the important part is the facilitation, and that can be done within the practice by allied health or nursing staff or secretarial staff or clerical staff, whatever you call it these days. Sorry, bit of a boomer, so I don't know the term for that. I should learn it. But support staff. There was an article in the MJA in 2020 which highlighted, it was basically called Crisis as Opportunity, How COVID-19 Can Reshape the Australian Healthcare System. And there were 3 problems identified, the 3 core problems, sorry about that, which were basically siloing and poor integration, which causes lots of duplication of services, an emphasis on treatment rather than prevention, and the monumental wastage and inefficiency. And we think that shared medical appointments addresses this really beautifully, so hence our passion. The bottom line really is the important thing here. This is studies done by Eger and Stevens, and there's a reference there. You can read a bit about it in Australian Family Physician, and if you just Google Shared Medical Appointments Australia, all of the work of Gary Eger and John Stevens and et al. Comes up. But really the important thing is the feeling of support for GPs, the management of waiting lists. It's really a supply and demand solution, and gives further enhanced time to address the educative questions, because you're interacting with one patient and another patient might make a cue that they don't understand, or they might want to say something how their case differs, and everybody gets to hear what's applicable to everybody and nuanced for the individual. So the shared message is heard by everybody, and the nuances are understood, which increases health literacy and makes people realise how important the face-to-face appointment is as an enhancement of shared medical appointments, or how shared medical appointments enhance face-to-face. Yeah, so the bottom line here, you can read the advantages there, but the bottom line for patients was improved patient health and well-being, and enjoyment of the experience and engagement of the experience. After this, this is a very brief slideshow, but after this I'd like to talk to Karen, because we've been running these sessions in private practice, but virtually, and it'll be interesting to hear Karen's experience and how it contrasts with Mark's. So that was Mark Davies from Lara. Basically, Mark, actually one of those patients in that group, so this is at Lara, and Michael Homewood told me yesterday that one of those patients dropped his HbA1c from 9 to 6 and has maintained that since the shared medical appointments, which is a dramatic, if that was a drug, you'd definitely market that one with a fair bit of enthusiasm. So we're very excited, and that wasn't just one person. Every person in that shared medical appointment had quite a lot of clinical improvement in both their biomedical parameters, but more importantly in their feelings of autonomy and independence. So for the clinics, and this is an interesting one, containment of costs while increasing efficiencies. And there are some patients who do really well. Part of the facilitation is managing the patients who have a lot to say, and making sure that you can use them as a resource, and also the patients who don't have a lot to say, because they can be quite, the triaging, you can leave them towards the end and check with them about what they want their participation, and that triaging enables them to just listen passively, and they almost always become engaged. That's one of the really big advantages that Gary and John have noticed. They've been doing shared medical appointments for 10 years. The other really important application is Indigenous groups, where they call them group yarns. And because it's about sharing stories and sharing experiences, it fits really fits really well in their experience. I'm sorry that you couldn't hear the video. I'm just getting messages about the video, and it worked perfectly in testing. So it is on YouTube, the video. So if you Google Shared Medical Appointments and Lara Medical Centre, or LMC, you can hear the whole video. It's very short and it is worth listening to, so my apologies. There's research on shared medical appointments. So this is a paper from Kirsch and the references there. The interesting things I've circled: combats isolation. Virtually everyone and it'd be interesting, Karen, I might ask you here, when we did patients who were on dialysis, and these are patients who knew each other, this isolation issue, do you want to just say something about that?
Yeah, sure. So the first, I guess, test we gave of shared medical appointments was with a group of patients that were on dialysis that I knew very well. There was 5 of them, I think, and of those 5, I think at least half of them were on a dialysis session with each other. And if you know what a dialysis unit looks like, they're obviously all sitting very close to each other. But interestingly, other than sort of nodding hello, hadn't really interacted. And we brought those 5 people together for 3 sessions. And it was really to be a university teaching session, talking about just their journey in navigating the health system with kidney disease. And it was just fascinating how the peer support that these individuals gave each other was quite extraordinary. And they would say things that they'd never said to me on a one-on-one. They just used different language, which was really fascinating. So I'd known all of them. The shortest was about 9 months and the longest was many, many years. And they would talk, I think the one was about the feeling of fatigue, and they didn't actually use the word being tired or lack of energy. Somebody said fatigue, and then the next person said, yes, that's it. It's far more than just being tired. So it was fascinating. So the language was quite different. Their interaction was different. And I certainly felt I knew them on a different level after doing just these 3 sessions with them.
And also they knew each other, didn't they? Like they said, oh, I thought I was the only one going through this.
Yeah. So that was the fascinating thing for something like kidney failure, where you are on dialysis, and there's a lot of, you see each other every day, and you think you know what dialysis is meant to be like, and yet, there were things that they didn't realise that other people were experiencing, such as the fatigue. Loss of taste was one.
Yeah.
So rather than just being off your food and nauseated, someone eventually articulated, no, I just can't taste the food. And so it was fascinating, that part. Yeah.
Thanks, Karen. Yeah, so basically the research supports our experience. We've been blown away at how refreshing these sessions are. Both of us walking away from the session just feeling invigorated. But we'll talk more about the experience. I've nearly finished the presentation. Medicare. Now, this is an issue that has been I would say a mission for 10 years to get Medicare to recognise and adequately fund shared medical appointments. There are workarounds, and at the moment they're probably cost neutral, using some special item numbers. People worry about whether they're actually Medicare authorised, and this is the best ruling that anyone has got after pressing Medicare. It's very hard to get a yes or no, but you can see patients consecutively, and it has to not be a group session. Now, a group session is family members or close intimate relatives, but the group session doesn't define people who don't know each other. So it's not a group session under Medicare. So it can be individual consecutive appointments with individual patients, and it has been run as such. But one of our visions is to push Medicare for actual better recognition than this, because it is going to solve a lot of Medicare economic problems. And that's the end of the squawking. And I don't know if you feel like taking flight, but one of the things about one of the things that we're getting squawks from Jack to emphasise it. So look, I'd like to now just move to stop sharing my screen and talk to Karen just about her experience, but also welcome questions. And once again, apologies for the audio. So stop share. Yeah, so yeah. Privacy issues between patients. Thank you. Do you want to address that one first? And I can too.
Yeah, sure. So from a privacy perspective, shared medical appointments have been run for many, many years now in the US, and there haven't been any issues that have arisen in terms of from confidentiality and whatnot. For the individuals that we have in the shared medical appointments, we get them to sign a confidentiality agreement, and at the start of each of the appointments we talk about the importance of if they wanted to talk about some of the things that are discussed in a very general way, that is fine, but there mustn't be anything that is identifying. So we've not run into any difficulties with any privacy issues, and I would suggest that this is probably more private than what it is inside a general medical hospital ward, and probably also more private than in an outpatient setting where certainly from a kidney perspective, people are talking about their ailments all the time. So we haven't run into any strife from a confidentiality perspective.
Yeah, Gary Eger and John Stevens talk about this too. The confidentiality worries for patients dissolve almost immediately. You form community, and people become quite candid, and they talk about even men sharing their impotence issues and things that normally you would expect would be confined to face-to-face. We are very careful, though, to say to people, we're going to check after you've shared, and talk to the group. So if somebody, because you can feel quite safe in shared medical appointments, but you also need to know that people are taking your information away. So it's part of the facilitator's job, is to just check at the end, hey, look, you've shared these things. What are you happy to share? How long are the sessions?
I'll read the questions out for you.
Oh, thank you.
Yeah, that's what I'm meant to be doing. So.
Oh, sorry. Yeah.
So Kathy Turner, just a vote of confidence, really. Shared medical appointments bottle the power of groups. It has to be the way to go. So that's great. And Jill Ramsey asks, how long are the sessions with the group?
Yeah, they're generally around about 2 hours. So the first thing is the triage. So the facilitator, now I'm a non-practicing GP. It does actually help to have some medical information, but you don't need much. That's me. So I triage because there are themes. So everyone's asked, what do you want to talk with Karen about today? And then when the themes tend to overlap, that person who represents that theme becomes the first person, because it's common to a lot of the group. And so whereas someone might have a very individual issue, and that needs to be carefully triaged. But 2 hours is about the time, about 15 to 20 minutes for triaging, then the session for about an hour and 45 minutes after that.
Yeah, I guess just to say to that, in terms of the group size, so 2 hours seems a reasonable amount of time. So anywhere between sort of 10 to 12 patients is thought to be a sort of an ideal size, so that you've got that peer support, enough interaction, and not too many. Michael and I have been trialling a group via Zoom. We started during the sort of big surge in Omicron, and we only have 4 in that group, and via Zoom, as we're learning, that's been really helpful. And these are people that have come into my practice, so they've got a combination of kidney disease, metabolic health issues, refractory hypertension, and diabetes. So quite a range. And the 4 has allowed really. They've been spoiled. I think we've given them lots of time. So you could certainly it will be more efficient if you have a few more people in that group.
Mm-hmm. So can I just add too, we've had students in that group as well, because we've been using it as a deacon teaching session. The students have been fantastic, and they've just now run their own shared medical appointment on shopping and cooking choices with the patients. And that's there's a lot of potential for involving allied health supportive staff, bringing specialists in.
No, give me a sec. Elizabeth Cowling, where do we find out more about small medical appointments and how to be trained in them? I mean, is that your vision that GPs or that people will be doing these within their practices, or do you think it'll be outside their practices?
Well, I'll start. So it's part of the vision, I think, Anne. I think this could be, it really addresses many of the issues with the current health system, because I think everybody appreciates that the way we are delivering healthcare is not fit for purpose. It's very reactive and episodic, and what we actually need is something that can be very preventative, allow for early detection, improve health literacy, and I guess really empower patients or individuals to take control of their own health. So I think it certainly would be wonderful in general practice, and I think that's where a lot of shared medical appointment experience is. But I would suggest that even from a nephrologist perspective anyway, in my practice it would be an amazing addition. And when I first saw shared medical appointments, it's just like, this is so speaking to kidney medicine, people with early CKD, with renal failure following transplantation, for example. So yeah, I think it can go across the board, and I think there's a number of different ways it could be implemented. It could be for preventative healthcare. I think any chronic disease could be utilised in this fashion. I would like to really try it out in the early detection of kidney disease, which is there's obviously a big issue with early detection, and the other one that we've toyed with and we sought funding for, but unfortunately weren't successful, was for long COVID, which I think is a huge practice gap. In terms of training,
yeah.
You want to do training?
I wonder. Well, Karen just recently trained, so the Australasian Society for Lifestyle Medicine has an online training module to learn to be a facilitator, and they have a lot of resources. I think, I'm pretty sure you have to be a member to access that. We're working very closely with ASLM, as they're called, Australasian Society for Lifestyle Medicine, to be part of the training. So we want to train the trainer. It's part of our vision. This is not sustainable if it's just champions doing it in a little enclave.
There might be a few advocates amongst our audience that, getting in touch maybe. It sounds like a really great idea. Lots of people love the idea. Jill asks, how difficult was it to start the idea amongst patients? Was there reluctance at the beginning before people knew about it? And it sounds fantastic.
Okay, yeah, perhaps I'll start with that, because we did this, the first one of this was a few years ago at GMHBA, and we engage, and we still have actually, the way we approach the patients is, you're actually not just patients, you're actually part of a new movement and part of co-design. And so this is about the flexibility that Millie talked about before. When you start shared medical appointments, as John and Gary say, if you've done one shared medical appointment, you've done one shared medical appointment. They're very, very different each time because they are very patient-centred. And that's where I think the training is really important. It's not rocket science, but and Anne and I have done the same training for the communication skills through the, I can't say the long word, but there's a whole organisation.
Office of Health, patient-centred.
Yeah, something like that. Anyway, I wish I'd learnt those skills at the beginning of general practice, because it just makes it so much easier to go, I need to respond to that verbal cue. I need to signpost this. I need to do a patient summary, get the patient to do a patient summary of what they've heard. I need to get the doctor. So I might say to Karen, can you just summarise what you've just said, because I noticed that Jed was looking a little bit confused. That sort of training is really the important part, but it isn't rocket science. It is very basic communication skills. So have I strayed from the question because of my ADHD? Yeah. Sorry, Anne, over to you. Did you have anything to add to that, Karen? No, it was just about, no, can I? Yeah.
From training, that's what we were talking about, training. So I think I think the facilitator probably has the more challenging role in this, and that's where the training is obviously key, and the comm skills. From a clinician's perspective, I'm really guided by the facilitator, so that seems to me the key. In terms of facilitation, I think I'm really lucky to have Michael as part of the facilitating for me, and to have someone with a different skill set that can contribute to the patient care. A lot of facilitators have traditionally been allied health, and I just think that is an incredible luxury if you had a dietitian or an EP or somebody that was facilitating but also could provide clinical care. And I suspect that would also help in terms of driving your business case and whatnot. From a clinician's perspective, it is get in and have a go. It's not much different to what we're normally doing one-on-one, but just in that group setting. So the clinical, the doctor side, actually, I don't think there is that much training. It's the facilitator training to be able to manage that crowd. Our vision is that we're training some of the medical students at the moment, training, that's not the right word. They're learning, some medical students are learning. And we were just sort of toying last week, actually, about another idea. And I'd love to set up a clinic that becomes almost a student-led clinic, but allows that facilitator and doctor training, so it becomes as commonplace as sort of our general, face-to-face, one-on-one interaction.
The patients love it. They get engaged very quickly, and they walk away saying, "Oh, look, this has been like it's the amazing thing that I think that what keeps us energized is that everybody walks away thinking, this is better. It adds on, so it's not a replacement, but it really enhances medical care. Their sense of independence and autonomy, but also health literacy. The thing that brought Michael's patient down from an HbA1c from 9 to 6 was simply health literacy, knowledge and nutrition. Like, we go for the low-hanging fruit, so it's really nutrition, activity, smoking, of course, and alcohol, but also sleep and also emotional eating. There's a lot more than just saying, do lifestyle advice, which apparently one of our students overheard in general practice the other day. Do lifestyle things, and here, take this tablet. And it's what is the lifestyle things, teasing that out, that's really important, and that gets a lot of attention. There's a lot of emphasis on prevention, or we reckon we can reverse a lot of disease. The upstream determinants, for example, for essential hypertension, they now reckon it's 85% lifestyle, and we can attend to that. I'm going to stop talking. I'm getting carried away.
I'll just read the next question. The reduction in social isolation is really impressive. Similarly, a key part of the Spring into Step program, as Millie presented, is the social involvement of the people in the groups. Finally, the work that Maria Singh in Sydney has done for decades. I'm having trouble making that move up.
On group resistance training sessions shows the social benefits as well as the improvement in medical outcomes.
So
Anne's frozen.
No, she's back. Yeah. So I would suggest that probably the most potent component of the shared medical appointment is that peer support. And it's just quite striking when you see this a group together and how they bond very quickly and support each other. We found that in the group that we did with the metabolic health, and that we're still doing at the moment, that was quite extraordinary how one would find would disclose their strategy. This is what works for me. It might work for you. So I think that peer support is actually really, really important.
I want to just leave you with a quote, because we're just about to finish up, but I love this quote that says, "Friendship is born the moment when one man..."
While it's dropping out, I might just quickly say, where can I sign up for training? It's at ASLM, so this Australasian Society for Lifestyle Medicine, but please get in touch with us. I don't know how, contact us. I can share emails and things to people. So get in contact. Sorry, Anne, your quote dropped right out. Do you want to say it again?
I'll try again. I just thought it summed up what you were saying was, friendship is born at the moment when one man says to another, "What? You too? I thought I was the only one." That was C.S. Lewis that said that.
Yeah, fascinating. How did you bring that up so quickly? It's so, and that's the patience. And really that, when you look at the upstream the longevity predictors, the most important predictor is social engagement, and the second one is strong relationships. And that's where I think medical appointments really works. Number 10 was air pollution, by the way.
Anyway, thank you so much. We'll all clap in our rooms. It's an inspiring talk, and I think we're all inspired, and hopefully we can get this happening.
Yeah, get in
Thanks,
touch
everyone.
with us. Thanks.
Yeah.
Bye.
Bye.